Sir, please share your slide, sir.
1 second. So I think the slides are visible.
Yes, sir, they are visible. You can just put it on the slide mode. So.
Hello, ma'am. The webinar is now live streaming.
Yeah, okay. So I would like to welcome Dr. Parveen Jain, Dr. Shalabh, and Dr. Ankur for presenting a unique panel discussion that will help us to uncover the role of CDK4/6 inhibitor in raising the standard of HR positive HER2 negative metastatic breast cancer. So I'm sure we'll have a great understanding. And over to you, Dr. Parveen.
Thank you. So thanks a lot, Pfizer, for giving me this opportunity and for this panel discussion. So it's not a panel discussion exactly. It will be a interaction about the practices, about the viewpoints, and I'll invite the experts, which I'm going to discuss with Dr. Shalabh, who is a consultant medical oncologist in Ujala Cygnus Central Hospital, Haldwani. So Dr. Shalabh is here, and Dr. Ankur Vashne, who is a consultant medical oncologist in FMRI Gurgaon. So both of you, I welcome you guys for this discussion. And today we are going to discuss regarding the CDK4/6 inhibitors, and we've been discussing CDK4/6 inhibitors since 2015 in HR positive HER2 negative breast cancer. So, but recently there was overall survivals, so which were reported with Ribo, Abima, and Palbociclib. So we are going to dissect the data, and we are going to see what is exactly happening in the CDK4/6 world. So these are my disclaimers. The slides are provided by the Pfizer. So these are various phase 1, phase 2, phase 2 and phase 3 trials of all these three CDK4/6 inhibitors, and consistently they have shown a similar kind of PFS advantage, but there was some discrepancy in the overall survival advantage. Ribociclib and abemaciclib, they had shown significant overall survival advantage in some of the trials, and palbociclib in Paloma 2 so couldn't show any significant overall survival advantage. And because of the discrepancy in the inclusion criteria of these trials, and because of the discrepancy in the result, so there was a confusion which one to use, whether to use palbociclib or ribociclib or abemaciclib, and is there a OS advantage only with the ribociclib, abemaciclib, or it's a class effect. So to answer those, so this was a meta-analysis which was published in 2020, and it showed that taken together, and it was on the basis of individual patient data, and it was shown that there was a significant PFS as well as OS advantage with all of these agents taken together, where all phase 2, phase 3 trials of these agents were included. So with this background, so we go on to the polypharmacology of FDA-approved CDK4/6 inhibitor. We know abemaciclib, ribociclib, and palbociclib. These are the three agents approved, and some says that they are almost similar agent with different toxicities. Some says that they have different activities, some off-target activities. So this was the paper which tried to look at the pharmacology of all these three agents. And in this chart, we can see over here the IC50 values of different CDK inhibitors, CDK4/6 inhibitor. And these are the various CDK cyclin D complexes which are involved in the cell cycle progression. And we can see over here that the off-target activity of abemaciclib, so this was the highest. So this is the desirable effect which we want, the CDK4 and CDK6 complexes activity. So this is the desirable one. But if we see other CDK cyclin complexes, so these are the off-target activities. And previously, when we started with the CDK inhibitors, so there were non-selective CDK inhibitors which were having all these kind of activities, and abemaciclib is exactly mimicking like those non-selective CDK inhibitors, and because of which it has more toxicity. And at the other end, it has some activity in those patients who are ribociclib and palbociclib resistant. And this is the reason why it is happening like this. So my first question is, according to you guys, so are all three CDK4/6 inhibitors same, or do you also think that they are different drug with different side effect profile with different efficacy? So Dr. Shalab, so what is your viewpoint on this?
Sir, I think now we have good enough data to tell us that all the three are efficacy wise, they are pretty much the same. And even a network meta-analysis is now published, which shows that there's practically no difference between these three drugs. And but side effect profile, I think to a large extent is different. And practically that is what we use in our clinical practice to decide between one or the other agent.
No, but regarding the abemaciclib data, that it is in some patients who have resistance to palbociclib and ribociclib, so they are still some of these patients are sensitive to abemaciclib.
Yes.
So you must be aware of it, and the data of usage in visceral disease, liver disease, where some of these agents work better. So any point of view on those aspects?
So, sir, I think in visceral disease and specifically now talking about visceral disease in patients with brain mets, I think palbo would not have such good activity, and ribo would be my go-to drug in those cases.
Okay. Okay. So, Dr. Varshne, so your take on this?
I agree with Dr. Shalab. In patients who are not having visceral mets and in without any brain mets, asymptomatic patients for mets, I found the clinical efficacy is the same. And regarding the side effect profile, abemaciclib has a very toxic profile. I'm not having any patient who doesn't have a dose reduction with it. So palbociclib is a better tolerated drug. Regarding in patient who has previously treated with the CDK4/6 inhibitors and who is having visceral crisis. Regarding visceral crisis, I prefer patients with chemotherapy. But brain mets and previously treated, I prefer abemaciclib.
Okay. So I think we have a consensus over here that efficacy wise, if we see, so all these three drugs, they are almost similar. So yes, there is a bit of evidence where there is cross resistance between ribociclib and palbociclib. Abemaciclib, I told you that it works more of a non-selective kind of CDK inhibitor, so it might have some activity which is non-cross resistant to ribociclib and palbociclib. But as such, in our clinical practice, what we have seen is that these drugs, they are having similar efficacy, and definitely out of the toxicity profile, so they are different. And palbociclib, I think we have the vast amount of experience. This is the most used drug and a time-tested drug, and we have used it in quite a few number of our patients. So coming to the palbociclib data, so that is the Paloma-2 updated analysis, which was published in ASCO 2022. And to just summarize the study design, so Paloma-2, this was a phase 3 trial, multicentric global trial, and they included postmenopausal women with hormone receptor positive, HER2 negative advanced breast cancer. And these patients were treatment naive with a PS of 0 to 2, and these patients were randomized into 2:1 fashion to palbociclib plus letrozole and was compared against placebo plus letrozole. And the drugs were continued till progression. And the primary endpoint of this trial was investigator assessed PFS, and the secondary endpoints were overall survival, overall response rates, safety, biomarkers, and patient reported outcomes. And there were various stratification factors as well, whether the disease is visceral or non-visceral, and with a DFI of less than 12 months, more than 12 months versus de novo metastatic. One thing I would like to make very clear over here is that there was a difference between the palbociclib, ribociclib, and abemaciclib registration trials. So abemaciclib and ribociclib, they had only included the endocrine sensitive patients, and Paloma 2, it included endocrine resistant as well as endocrine sensitive patients. And this was the difference between the trial schema. And the further stratification factor was whether the patient had received some neoadjuvant adjuvant hormonal therapy or not. And with this, the baseline characteristics, so they were equally matched. We can see over here, sorry. So we can see over here that almost 40% of the patients, so they were de novo metastatic in both the groups, and 22% of the patients in both the group, they were endocrine resistant group. So these were those patients who had a DFI of less than 12 months from the end of adjuvant to recurrence. And so they had included those patients also who progressed within those 12 months, and they had included those patients also who progressed on endocrine therapy. So this was the primary analysis, PFS analysis, which was published in 2016, which showed with a maturity of 43.7% for PFS events. And it showed that the median PFS with palbociclib was 24.8 months and 14.5 months with the placebo plus letrozole. And in 2017, the final PFS analysis was published with the full maturity of 55%, and the final PFS was 27.6 months in palbociclib plus letrozole arm, vis-a-vis 14.5 months with the with the placebo and letrozole arm. So the delta of this was close to 13 months, and this was the survival disposition. So total 666 patients were included in this trial, and 444 patients were randomized to palbociclib plus letrozole, and 222 patients were randomized into placebo plus letrozole. So out of these 444 patients, so there were missing survival data for 13% of the patients, and 10% of the patients, they are still on treatment in the palbociclib plus letrozole arm. In the placebo plus letrozole arm, we can see over here that 21% was the missing survival data, so which can definitely influence the survival analysis of this arm. And 2% of the patients were only on the placebo plus letrozole treatment. So we can see the overall survival. So this was the overall survival which was published in ASCO 2022. And we can see there was no statistically significant median overall survival advantage, but there was a numerical advantage in favor of palbociclib plus letrozole, and the p-value was 0.3378. So if we go deep into the subgroup analysis, so we can see over here that the ECOG performance 0. So there was a discrepancy, the disproportionate missing survival data. So in 11% of the patient with palbociclib plus letrozole, so the data was missing, vis-a-vis 28% of those patients in placebo plus letrozole, so the data was missing. So this ECOG 0 subgroup, it had maximum disproportionate missing data between the two arms. So because of which the letrozole arm performance was unprecedented. And if we see the subgroups where the disproportionate data was minimum, so that was the ECOG performance 1 or 2, then DFI more than 12 months, that means the endocrine sensitive population, then those patients who had received prior endocrine therapy, prior chemotherapy, and those patients with bone-only disease. So we will discuss the so this was the post hoc analysis. So where they had excluded those patients where the survival data was not available. And this showed that numerically there was an advantage, incremental advantage of palbociclib plus letrozole after excluding those patients. And the delta over here was close to 7 months, but the p-value was again non-significant, and the hazard and there was no statistical improvement in overall survival. So they also, so this was the Paloma 1 and 2 combined OS analysis. So this was the pre-planned analysis. So they had pre-planned it that finally they are going to merge both the trial and they are going to publish the overall survival, combined overall survival analysis. And in all patients, if we see, so the median OS was 51.8 month in the palbociclib plus letrozole and 46.8 month in the control arm. And again, so it was not statistically significant, but when they tried to look in the endocrine sensitive population with a DFI of more than 12 months, and it was an unplanned analysis. So this was not a planned analysis, it was an exploratory analysis, and they found out significantly better overall survival advantage in palbociclib plus letrozole arm in those with endocrine sensitive disease, with a median overall survival of 64 months vis-a-vis 44.6 months, and the hazard ratio was 0.736. So this was in the endocrine sensitive population. And there were other reasons which were published that why palbociclib did not show overall survival advantage, because 27% of those patients with who were in placebo plus letrozole arm, so they received CDK4 inhibitors, 4/6 inhibitor in the later line. So this was probably one of the reason which was documented why which had added to the overall survival discrepancy. So there were other parameters where the palbociclib had edge over the placebo plus letrozole. So one was the time to chemotherapy. So this is again a very, very important endpoint as far as hormone receptor positive HER2 negative breast cancer is concerned. And the median TTC was 38.1 month with the palbociclib plus letrozole and 29.8 month with the placebo plus letrozole, which was statistically significant. And these are the three registration trial which have been compared together. So we can see over here the inclusion criteria, the baseline characteristic. The Paloma 2 included 22% of those patients who had endocrine resistant disease. So this particular subset was excluded both in Monarch 3 of abemaciclib and Mona Lisa 2 of ribociclib. So probably they had only included the best patients who will do well with the endocrine plus CDK4/6 inhibitor. And if we include other trials of Mona Lisa also in this, so we can see over here that Paloma 2 included 22% of the patients with endocrine resistant disease. Mona Lisa 3 did not include any of these patients, and Mona Lisa 7 and Mona Lisa 2 they included only a minor minor number of patients with endocrine resistant disease. So if we see 40% of the patients with Paloma 2, they were having endocrine sensitive disease where the DFI was more than 12 months, and the DFI of more than 24 months was not reported in Paloma 2. And we can see here that the good biology of disease patients where the DFI was more than 24 months. So it was close to 60% in Mona Lisa 2. So this is something that the population which was selected in Mona Lisa and Monarch, so they were biologically better population as compared to the Paloma population. So again, coming to your viewpoint, Dr. Varshne, so what do you think about the Paloma 2 subgroup results, which I just showed with the endocrine sensitive disease? And do you think that endocrine sensitive subgroup is driving the OS benefit in other CDK4/6 trials? So Dr. Varshne.
Yes, sir. I agree with the concept because maximum patient in the Mona Lisa were those patients who have DFI greater than 24 months amongst the 60% patient in the previous slide as you showed. So this is the main reason that they are having an OS benefit. Also, a cross trial was also there in the Paloma group.
No. Do you think that this is the only reason why they had a better overall survival? because there are other reasons also which I mentioned over here.
Mhm.
So do you think this is the sole reason or this is the predominant reason for
This
that?
is an important reason, basically.
Okay.
Basically, important reason, and also because abemaciclib is a third generation drug, which usually cover resistant clones also.
No, but here is a point which I want to make. So there was a individual analysis of Paloma 2 also which was published. So there they also had tried to look at those patients with a DFI of more than 12 months. So there numerically the advantage was there, but statistically the advantage was not there.
Hmm.
So
But
this
sir,
is
that was
another.
an unplanned analysis. No, that was not, trial design was not directed towards OS.
No, what I mean to tell is that there is another thing which is playing part in this. So it is not only the sole factor. There are other factors also, but this is the predominant factor as far as we are thinking in these terms. So coming to Dr. Shalab, so what is your take on this?
Sir, I think it just boils down to one very important point about patient selection whenever you are doing a trial. So if I can extrapolate from something similar results we have in the adjuvant setting, where Pallas trial failed to show significant benefit, whereas abemaciclib showed a lot of benefit in monarchy and it's approved. So I think patient selection is so important because here 22% patients have been selected who are sort of endocrine resistant. This trial was bound to show results that are inferior to the other trials. So, I mean, patient selection is extremely important. And in this trial, probably that has significantly contributed to dilution of their results. And
I totally agree to this.
yeah.
And what is your take on the missing data? So because there was a discrepancy in the missing data also.
Yeah, so there, again, I think that also is a good significant contributor of missing data can also, because I think the benchmark we usually use is you should not have more than 15 to 20% missing data. If you have more than 15 to 20% missing data, that sort of does compromise the credibility of your results.
Definitely. So the next question is, so in your clinical practice, so what will be the percentage of those with endocrine sensitive versus endocrine resistant population? So in hormone receptor positive patients.
So, sir, I think in my practice over here, which is, I would say, numerically numerically insignificant compared to what you're probably seeing in Delhi, I feel around 10 to 20% patients only present with upfront endocrine resistant disease. Most of the
Okay.
patients, in fact, come with who have a long period between their completion of adjuvant endocrine therapy, and then they come with metastatic progression.
Okay. Okay.
So,
So,
I would be keen to hear what sort of real world figures you are getting in over there in Delhi.
So Dr. Varsne, so I think
I also agree with this. Majority of patients are endocrine sensitive, and it also depends on the LRED score. Majority of 8 LRED scores are usually endocrine sensitive, and the lower score is usually endocrine resistant. 5, 6, if you have LRED score, they are usually endocrine resistant.
okay. So the literature says that almost 15% of the patients, so they are primary endocrine resistant. Almost 20 to 25% of the patient, they have secondary endocrine resistance. And 60% of the patients, 60 to 65% of the patients, so they have endocrine sensitive disease. So, but I totally agree with what you guys are telling me, because if I see my data, so close to 70% of these patients, they will be endocrine sensitive. And this is a very important aspect which we have to see. So whether the patient is endocrine resistant or endocrine sensitive, and whether the patient is having primary resistance or secondary resistance, because the mechanisms which plays part in the treatment which you are going to select next, so that really depends on that. So nowadays, whatever trials are coming with these ADCs, in like in TDXT, where HER2 low patients they are selected. So they have made an amendment in the inclusion criteria that those patients who have progressed within 2 years of starting of adjuvant therapy, that means primary endocrine resistant. So they are directly considered for a good candidate for chemotherapy. So according to these things, so endocrine therapy probably is not going to work in this subset of patients who have primary endocrine resistance. And secondary endocrine resistance, we definitely have to choose our endocrine partner also along with these CDK4/6 inhibitor. So now coming to a very, very important question, and which we have always faced in our clinical practice. So do you really think that CDK4/6 inhibitor will help in endocrine resistant patients? So as compared to only endocrine therapy, will CDK4/6 inhibitor addition will make a big difference in this population, or it is not going to make any difference? And what is the reason why you are thinking that way? So I also need to know that. So Dr. Varshne, I think we'll start with you.
Sir, in endocrine resistant patient,
Mm-hmm.
with the chemotherapy first.
What?
In endocrine resistant patient, I used to prefer with the chemotherapy first.
Okay, in secondary endocrine resistant patient also. So like a patient comes to you who has completed adjuvant treatment just 2 months back and now has presented with few bone metastases. So will you be going ahead with the chemotherapy?
Sir, I will offer such patient. Usually bone, if patient is asymptomatic, we can try. But we know that the outcomes will be inferior in these patients.
Okay.
So I offer the patient that this is the data, and we may go with the oral therapy, or we may opt for IV therapy also.
Okay. Okay. So Shalab, so what do you think? So what is, so if a patient comes to you who has progressed on endocrine therapy, so what do you think? So will be the resistance mechanism which will be coming into picture?
So, sir, CDK4/6 itself is a major resistance mechanism in patients who fail endocrine therapy, and that's the main reason we are now trying to include CDK4/6 directed therapy upfront. In primary endocrine resistance, for most of my patients, I would definitely give them a trial of probably fulvestrant plus CDK4/6 if they have not received it in first line. And but again, I agree with Dr. Ankur that these patients will probably have a short-lived response and I'll need to escalate to chemo soon enough. And
I totally agree with this. Yes, please.
And for secondary endocrine resistance, I'm a little more positive. I'll still start with fulvestrant along with the CDK4/6 inhibitor if they have not received in first line. And these people will usually have a little more favorable time to chemotherapy as compared to primary resistance.
Yes. So so I would like to tell is that these patients who are having a secondary endocrine resistant disease, so the most common resistance mechanism is the ESR1 mutation, and this is a kind of mutation which develops during the endocrine therapy, and the incidence of the frequency of this mutation, it keeps on increasing with the amount of endocrine therapy, and it is seen in the PADA trial as well. And so this mutation, ESR1 mutation, ultimately this leads to cell cycle progression in breast cancer. And that is the reason why CDK4/6 inhibitors, so they are considered along with endocrine therapy in secondary endocrine resistant patient, predominantly who have this endocrine receptor based mechanism of resistance for endocrine therapy. And this is to show that in palbociclib also. So if we see the magnitude of PFS benefit in those with DFI less than 12, that means secondary endocrine or endocrine resistant disease, and those with the endocrine sensitive disease, so it was similar and it was significant. So the HR ratio was 0.5. So that means, so palbociclib, it worked very well in the endocrine resistant disease also and in the endocrine sensitive disease also. But if we see the OS advantage, so this was numerically there, but it was not statistically significant in favor of palbociclib plus letrozole. And this is probably because of all those reasons which we had discussed in the previous slides. So it is missing survival data. So the type of population which was selected, all those things they were contributing to that. So we were talking about the acceptable loss to follow-up or missing survival data in clinical trials. So this is the rule that in randomized controlled trial, so typically investigating drugs or other therapy, it has been suggested that a loss to follow-up of more than 20% poses serious threats to the validity of the data, and even more than 10% may pose biases in the statistical analysis. And if we remember, so in the placebo plus letrozole arm, so there was 21% patients who had missing data, missing survival data, and in the experimental arm of palbociclib plus letrozole, 13% of the patient, they were not having the survival data available for analysis. So this is something which is very, very important to look at, so that it was unacceptable missing survival data numbers which were there in the placebo the standard of care arm and the experimental arm. So this we had already discussed what impact of loss to follow-up data in both treatment arms. So coming to the trial endpoint, this is one more point which we should discuss. So the primary endpoint of this trial was PFS, and this was not overall survival. So according to the National Cancer Institute Breast Cancer Steering Committee Working Group report, so they convened a working group of breast medical oncologists, patient advocates, biostatistician, and license from the FDA to conduct a detailed curated systemic review of the literature to determine the current landscape of therapeutic options, recent clinical trial data, to know about the appropriate endpoints for the clinical trial. And so they had subgrouped the breast cancer into triple negative, HER2 positive, HR positive, HER2 positive, and HR positive, HER2 negative. So in the first line trials, so in triple negative metastatic breast cancer, so because the subsequent number of therapies, so they were less, so overall survival was termed as the best primary endpoint, and response rate and patient reported outcome were termed as a best secondary endpoints. But if we see the HR positive, HER2 negative subgroup of the patient, so the best primary endpoint in first line is the PFS, because the patient has to receive so many lines of therapy, subsequent therapies, that the overall survival analysis will not be a true representation of the benefit of the drug which is used in the first line trial. So this is something which I wanted to bring to your notice, that in HR positive, according to the NCI Breast Cancer Steering Committee, PFS is the best primary endpoint. So considering Paloma 2 data readouts and their limitations, do you consider OS a class effect for all CDK4/6 inhibitor? And if not, why? So, Dr. Shalab.
Sir, I think based on the steering committee recommendation that you've just shown, now this question is just a rhetoric, because PFS is a good enough marker, and we can base our clinical decisions on the PFS in this subset of breast cancer patients.
Okay.
So
Doctor,
I'm convinced that CDK4/6 as a class, they improve the PFS, and which will translate into OS later down the line.
okay. And Dr. Varshney, your take on this?
I agree with the same. But after seeing this presentation, I agree that PFS is significant outcome, and we should give benefit of this to our patients.
No, but what do you think that like Paloma? So the same thing is applicable to ribociclib trial also and the abemaciclib trial also. So it was by chance that the Paloma 2 trial did not show a survival advantage. And do you consider that this OS, so which is seen with abemaciclib and ribociclib, so it is a class effect? So rather than being a trial effect or a a group of like ribociclib or abemaciclib only has a OS advantage?
To remain same, I think that because of loss of follow-up data with significant number of patients and also the selection of patients in the monolithic trial, it led to a significant OS difference. And regarding this, we can only comment when we haven't had a head-to-head comparison, which is doesn't seem possible.
So there is a trial. I think Novartis had started this trial recently where palbociclib is. There is a comparison going on with ribociclib head-on in first-line metastatic breast cancer. So I think that will answer all these questions.
It will answer these questions.
So regarding the toxicity profile, so we have used in n number of patients palbociclib, and we know the most common toxicities. So these are cytopenias, and most of the time, so they are grade 1, 2, 3. So very less number of patients, they have febrile neutropenia with palbociclib, and these are easily manageable, doesn't require most of the times any growth factor support, doesn't require any antibiotic support. So it is only a matter of time, and with after 2-3 cycles, 4 cycles, so usually these side effects improve, and there are very less number of patients who require dose interruptions and dose reductions. So regarding the Paloma 2 conclusion, Paloma 2 met its primary endpoint of improving progression-free survival and other secondary endpoint with an overall response rate of 55.3% in the experimental arm and 44.4% in the standard of care arm. And the safety profile of palbociclib and letrozole remain consistent with long-term use without evidence of cumulative toxicity, and there were no new safety signals which were observed in the follow-up analysis, which was published in ASCO 2022. OS was numerically longer in palbociclib plus letrozole versus the placebo plus letrozole arm, but the results were not statistically significant. And a median overall of over 50 months in this population represents a significant improvement in the natural history of HR-positive breast cancer. Interpretation of overall survival in Paloma 2 is limited by a large and disproportionate percentage of patients with missing survival data between the treatment arms. So coming to the real world evidence, not only in the randomized controlled trial, but the real world evidence also shows the benefit of palbociclib. So the Flatitron EHR database. So it is a 3 million patient record database. So from where like 75% of the data come from the community practice and 25% from the academic centers. And it was this Reality X, P-Reality X. It was a retrospective observational analysis on the basis of electronic health record, which were of the patient data from the Flatitron Health Analytic database. And these real world the real world studies, they are increasingly being used to understand the safety and effectiveness of new drug regimes in clinical practice and to examine the real world effectiveness among patients with HR positive, HER2 negative metastatic breast cancer. And definitely the real world evidence is, so they add to the evidence from the clinical trial of palbociclib based therapy. So the objective of this trial was to evaluate the effectiveness of first-line palbociclib plus anastrozole plus aromatase inhibitor as compared to aromatase inhibitor alone. And it was a retrospective cohort analysis of EHRs which were received from the US Flatitron Health Analytic Database. And the index date was the starting date of first-line MBC treatment. And those patients who started the MBC treatment between 3rd February 2015 to 31st March 2020 were included. And the patients were given palbociclib plus AI versus AI. And the primary endpoint of this analysis was overall survival. And the secondary endpoint was real world PFS. So for reducing the selection bias, because of the lack of patient randomization, there were two kind of statistical adjustment which were done. So one was the stabilized inverse probability of treatment weighing, and the other was propensity score matching. So with this, they had taken this trial, and the real world data studies. So there are a lot of pros and cons of the real world data, and the pros is that they include those patients who are not a candidate appropriate for the randomized control trial. So those patients are also included in the real world data studies. So they do have a large number of patients included in the real world data, and they also include the extreme of the ages also. So the treatment selection is often influenced by subject characteristics, because of which there are systemic differences which exist in the study population of both the interventions. So the real world studies, the limitation of real world studies is that there are a lot of biases which happens in selecting the patient. So one is the selection bias, then is the missing data bias, then is the confounding biases, then misclassification bias, and the reporting bias. So taken all together, the pros and cons of these real world data should always be there, and to reduce these biases, so this trial had taken two kind of statistical adjustments. So one was the inverse probability treatment weighing. So the aim of IPTW was to adjust for differences in characteristic of study subjects by adjusting weighing assigned to variables. And the goal was to create a pseudo population where all patients resemble a reference population. And the propensity score matching, the aim of this was to match patient across treatment group according to the demographic and clinical characteristics. And the goal was to compare patient with the same propensity score, but who received different treatment. So we will understand it in the subsequent slide. So this is how PSM works. So suppose there is a heterogeneous population which is indicated by different sizes. So what PSM will do, that it will the study group with matching will be done with the help of the PSM, and those sizes which are too big or too small, so those which are not representative of the study population, they will be taken out, they will be excluded, and only those patients who are matched, they will be selected for the further analysis. So IPTW, so it is a method that can be used to help minimize bias by in real world studies by creating a pseudo population where all patients resembles a reference population. So just like here, so sorry. So in this is the original population which has varying characteristics indicated by the different sizes. So what IPTW will do is that it will weigh all patients according to the inverse of their probability of treatment, and then it will create a pseudo population. And the advantage of this IPTW is that it enables all eligible subjects to be included in the analysis, and it is also possible to have more than two comparisons if you have the adequate sample size for it. So these are the baseline characteristics, and we can see over here. So this is the unadjusted total cohort, where you can see some discrepancy in some of the parameters, like PS0 patients were 37.7% in the palbociclib plus AI group and 25.4% in the AI alone group. So after IPTW and PSM, all these parameters, they were equally matched, so that the proper analysis can be done. If we see over here, this is worth noting that those patients who had progression within 1 year of therapy or 1 year of diagnosis of breast cancer, so they were also included in this real world study. So this is primarily the primary endocrine resistant population which were included. So these are the overall survival analysis. So this is the unadjusted analysis where the hazard ratio is 0.67 as far as OS is concerned, and the median OS was 53.4 months with the palbociclib plus AI vis-a-vis 40.4 month with the AI alone. And if we see the post SIPW TW analysis and post PSM analysis, so again the hazard ratio was 0.76 and 0.72, and the median OS in this analysis was significantly longer among patients who received palbociclib plus AI versus AI alone before and after SIPW and PSM adjustment. So these are the subgroup analysis, and we can see over here that all subgroup of patient, they had overall survival advantage in favor of palbociclib plus AIs. And if we see the PFS in similar kind of analysis, so all three groups, unadjusted analysis, post SIPTW analysis and post PSM analysis, so the median real world PFS was significantly longer among patients who received palbociclib plus AI vis-a-vis AI alone. So the strength of P-Reality X study was that the large sample size was drawn from an extensive database comprising more than 3 million patients. The Flatitron database captures and processes detailed patient-level data such as demographics, diagnostic information, extent of disease, laboratory values, treatment including line of therapies, dosing and regime, and patient outcomes. So that means the Flatitron database, it include all the patient related and disease related and treatment related characteristics into the picture, and the availability of a comparative control arm that allows a comparison of treatment similar to RCTs after adjusting for potential confounders, and the follow-up time was sufficient to obtain median real world PFS and OS estimate for both treatment arms. And the most important thing is the use of statistical techniques such as IPTW and PSM to balance patient characteristics to address bias due to lack of randomization. So these were the strength of P-Reality X, but there were some limitations also. It was a retrospective study, and it might be having some missing or erroneous data, because of which the causal relationship cannot be established. The disease progression was based on the treating physician's clinical assessment or interpretation of radiographic or pathologic result. There were no central labs, no central assessment of the radiographic imaging, while SIPTW and PSM were used to balance baseline and clinical patient characteristics. Unobserved variables cannot be fully addressed through these methods. Some subgroup analyzed may not have sufficient power due to sample size, and finding presented here may not be generalizable to the patient population not represented in the Flatitron database. So to conclude, in the P-Reality X real-world study, palbociclib plus AI was more effective than AI alone, and this evidence support the use of palbociclib in combination with an aromatase inhibitor as a standard of care for first-line treatment of patients with HR-positive metastatic breast cancer. So in fact, on the basis of these real-world data, so there was an expanded indication for palbociclib which was approved in 2019, and that was in the men with metastatic hormone receptor positive breast cancer, where the palbociclib plus ET was approved as a frontline treatment. So, my question here to Dr. Shalab. So regarding the relevance of Paloma-2 and reality OS in the clinical practice. So considering the wealth of data for CDK4/6 inhibitor across RCTs and real world evidences, do you think that there would be any change in treatment practice among CDK4/6 inhibitor? So now you know all the data, so you have pros and cons of all type of analysis. So will you change your practice? Will you still go ahead with same kind of approach in selecting your CDK4/6 inhibitor, or will it change somehow?
Sir, I think now that we have dissected the data, we are more convinced that this was the OS, the lack of OS benefits from palbociclib is, in fact, I would say it's just statistical methods that have brought this result. So I would be more comfortable now using palbociclib, since I'm convinced that it has indeed a OS benefit, which is sort of comparable to the other CDK4/6 inhibitors.
Okay, and will there be any subgroup where you will be taking this data with pinch of salt?
Sir, I wouldn't think. I think like what we initially said, since there's still some there is still some selection. What to say? Factors that I would take into selection is patients with brain mets, and in those patients, I would still probably prefer abemaciclib for a better CNS penetration. There's documented. So apart from that, no other significant difference.
So, Dr. Varshne.
Sir, I agree with the Dr. Shalab, and we will expand the patient cohort with the palbociclib. And another important reason will be now the cost. The cost of palbociclib has come significantly down as compared to the other CD46 inhibitors. So definitely more, it is in the pocket of more patients. So I find that
Yeah,
more patients will be recruited.
in India, everything's all down to the patient assistance program and the cost of the therapy also.
Mm.
So there
Yes.
also it is more patient friendly rather than ribociclib and abemaciclib.
Yes.
So I think this we have discussed in detail. So I'll just enumerate some of the Indian experience with palbociclib. So this was the paper published by my dear friend Chaturbhuj Agarwal. So this was the largest real world data from Indian population. So they combined patient from RGCI and BLK Hospital Delhi, and it was a retrospective analysis. In total, 188 HR positive HER2 negative metastatic breast cancer patient who received palbociclib plus aromatase inhibitor or palbociclib plus fulvestrant between 2017 and 2020 were included. And they also included premenopausal patients who received ovarian suppression or ovarian ablation. So they observed that the median PFS in first line was 20.2 months, so which was almost in so aligned to the Paloma 2 trial, and the median PFS in second line was 12 months. Overall response rate was 80%. So that was something which was way higher than the Paloma 2 overall response rate. It is close to 50% more than that. And the overall response rate in the second line was 47.9%. Only 10% patient had grade 3-4 adverse event, and 20% patient had neutropenia grade 3-4, while no patient had febrile neutropenia. So this is very, very important. So because most of these patients, they never require growth factor support, they never get admit with febrile neutropenia. So we are very comfortable. So even if a patient is having grade 3-4 neutropenia, usually we follow up that patient, and we tend to repeat the blood parameters every week. So so this was the real world data of palbociclib in Indian population. So there was another study from South India, so where 5 center collaboratively they looked at their data retrospectively, and 133 patients on palbociclib were analyzed. 62% of the patient, they were in the first line setting, and 37% of the patient were in second line, and the median age was 56 years. So here the point to make is that median PFS in the first line, so that was not reached after a follow-up of 38 months. So that means the PFS of more than 38 months in 133 patient. So that was tremendous. In de novo metastatic patients, 18 month versus not reached, and bone only versus visceral metastasis not reached versus 28 months. So these are the three subgroups where the palbociclib had made the magic. And if we see in the second line, the median PFS was 14 months. And if we see the bone only versus visceral metastasis, this was something which was lower in the bone metastasis, 14 month versus visceral metastasis. And if we see the safety parameters, again, neutropenia in 75% of the patient, most of them were grade 1 to grade 3 with no febrile neutropenias. 30% had dose delays, and only 8.2% had dose reductions. So it was almost the efficacy and safety was as per the Paloma trials. So coming to the another data from Cancer Institute Chennai, again retrospective, where the patients with HR positive, HER2 negative advanced breast cancer were analyzed, and what they observed was that the median PFS was 18 months and median OS was not reached, and 1 year PFS rate of 73.7%. So this was the data from Jaipur. So where they had included 51 patients, postmenopausal patient and 16 premenopausal, and in total 67 patients were given palbociclib, out of which 36% were in first line, 31% in the second line, and 33% in the third line setting. And what they observed was that the median PFS in the first line was 18.7 months, and in the subsequent line was 13.8 months. And the median OS in the first line was 23.2 months, and in the subsequent line was 16.3 months. So this was something which was way lower than the Paloma trial. But other than that, the data was was as aligned with the Paloma 2 trial. So this was the practical consensus recommendation published by Dr. Senthil Rajappa, and the take-home messages were like, in patient with metastatic breast cancer, available evidence doesn't support loco-regional therapy. The decision should be individualized based on patient and tumor characteristics, the site and number of metastases, and response to the systemic therapy. Endocrine therapy rather than chemotherapy is preferred in patients with HR-positive MBC. Chemotherapy may be offered for those who are highly symptomatic and visceral crisis needing rapid tumor response. A combination of AI and palbociclib should be the preferred first-line hormonal treatment for HR-positive metastatic breast cancer. Premenopausal women need to undergo ovarian ablation before starting on AI with palbociclib. If treatment with palbociclib is not feasible, AI should be offered. In patients with bone-only disease, fulvestrant may be offered over AI. So because the fulvestrant was having a very good advantage over AI in this particular subset. At present, ESR1 testing is not recommended in routine clinical practice. A combination of fulvestrant and palbociclib should be offered to patients who have progressed on an AI. Exemestane plus everolimus is another option who are not feasible for palbociclib. So this was again a paper published by Dr. Vaid in ASCO 2022, and they had treated 102 patients with palbociclib, and out of which 100 patients were included in the efficacy analysis. And what they observed was that the objective response rate was 17% in their patient, and stable disease was observed in 54%. And the most commonly reported AE was neutropenia. And finally, they concluded that the palbociclib plus letrozole reported good clinical response at the end of the treatment with a manageable tolerability profile. So to summarize, all of the CDK4/6 inhibitor pivotal trials were designed to demonstrate a benefit in the primary endpoint of PFS. And PFS is the accepted primary endpoint in metastatic breast cancer by regulatory authorities around the world. Increasing evidence is available from RCTs demonstrating longer OS with CDK4/6 inhibitor plus endocrine therapy versus endocrine therapy alone. However, the difference in OS was not statistically significant for palbociclib. The real-world evidence of associated OS benefit for patients treated with palbociclib combination therapy in first line can help inform treatment decision in clinical practice. And according to the worldwide guidelines, CDK4/6 inhibitor in combination with ET are the standard of care for HR-positive, HER2-negative advanced or metastatic breast cancer. With this, I think we will, I'll stop sharing. And I would like to thanks Dr. Shalab and Dr. Varshne for being part of this panel discussion and for this interactive discussion. I think if there are any other questions from the participants or from the listeners, I think we can take up right now.
Sir, may I ask one question?
Yes, no, please.
So, sir, do you look into molecular subtypes like luminal A, luminal B while treating a patients with advanced or metastatic breast cancer?
See, what we are doing is the IHC characterization of the tumor on the basis of ER, PR, HER2, Ki67 only. So we are really not looking into the molecular subtype or luminal A, luminal B. So I know. So there are a lot of debate over this. But if you see ER, PR, HER2, and Ki67, more or less you are able to categorize them into luminal subtype. But you are not going to do IHCs for luminal parameters or basal-like parameters. So those markers are still not applied. At my center, I do not really do that. Shalabh, what is your take on this? Do you really do the classifications?
Sir, I agree. We also do the same because basically for clinical practice, day-to-day practice, all we need is our treatment decisions are based on IHC itself and plus or minus FISH for HER2 when it's indicated. Molecular classification is not, it doesn't really impact our clinical decisions. So
And are you doing Ki-67 regularly?
No, sir, not routinely, not routinely. Though
Because again, Ki-67 is something which is very much observer dependency is there.
Yes,
So
yes.
one person will report a Ki-67 of 14%, another will report it as 2%, another will report it as 30%. So
Right.
Dr. Ankur, what is the practice at your center?
It's same treatment oriented. So we just do ISC and FISH for HER2 if needed. We didn't go for the molecular classification. It's mainly for the academic reasons.
And what about the Ki-67? Do you regularly do it?
No, sir. It's a highly observer variations. We don't do. We order only if we have to decide so that patient is a candidate for chemotherapy or we have to avoid chemotherapy.
So,
So
but
in
I
early
think
breast cancer,
Ki-67 is a very good marker. It is a very good marker, and nowadays with the availability of abemaciclib and regarding the treatment decisions, so also Ki-67 becomes important in selecting the adjuvant abemaciclib. Or so it was my thesis also, Ki-67, and what I had observed was that those patients who have a high Ki-67, and my Ki-67 cutoff was 34%. So those patients in neoadjuvant setting who have ERPR positive disease but a Ki-67 of 34%, those patients are a good candidate for neoadjuvant chemotherapy. So this again is it's a subtle thing. It is not a validated thing, but there are evidences which suggest that Ki-67 is a very good marker to select chemotherapy against hormonal treatment. So I think there is one question in the chat box. So when it comes to CDK4/6, what is your drug of choice and why? So I think we have already made this thing. Shalabh, sir, what will be your choice? So you already clarified that that you will be choosing palbociclib only in certain scenarios where there is brain metastasis. You might be keen in selecting abemaciclib, but
Yeah.
just to answer this question.
So just, I think we'll just, I'll reiterate that essentially all these three drugs are pretty much same except for brain penetration in abema. And now, like Dr. Ankur pointed out, now that the PAP for Ibrance is so good, so most of the patients, I think, will end up. In fact, just yesterday, I had this conversation with one of my patients who was on abema. I'm not sure if it's correct or not, but they asked me, like, can we switch over to palbociclib now that
we are on a daily basis? I'm getting these requests. Can we switch to palbociclib? Patient on ribociclib, abemaciclib, all of them they are asking.
So in
Dr.
that case, what do you advise, Dr. Parveen?
So I usually tell them that you should continue with same if financial crunch is not that much, because see, most of these agents, they have like after a limited amount of time the PAP comes into the picture and then they are eligible for free dosages.
Right.
So the thing is, it is a very critical thing to discuss and to decide, because if you decide that you switch to palbociclib and 2 months down the line the patient progresses, so they will say that we were fool to ask but you were not fool to advise.
Right. That's true.
So Dr. Ankur, so what will be your choice?
the majority the same I goes if patient is having brain mets either for abemaciclib. Otherwise, the cost is cost-driven factor, and majority of patient goes to palbociclib.
Yes, I think.
Sir, I have one follow-up question. Like previously, I was asked about the molecular subtype. So, because you have also touched upon the study of PAL-base versus ribo. So, sir, as far as my knowledge, it is Harmonia study,
Yes,
and
Harmonia.
sir, yeah, and it is basically in HER2 enriched patients, to the best of my knowledge, sir. So, if so, do you think, sir, the result will alter the practice?
Harmonia, I'm not sure whether it is in HER2 enriched population.
Okay.
Even I don't know the eligibility criteria, but technically
No. It is
It is for all patients.
it is for HR positive, HER2 negative breast cancers.
Okay.
technically speaking, those patients would not come for endocrine therapy
Yes.
upfront.
Yes. So love, it is for the same HR positive, HER2 negative.
Okay, sir. Thank you, sir. Over to Pooja.
Over
I
to
think you can conclude it.
Yeah, sir. Thank you so much for such an insightful discussion and so many details about the P-reality real world data. I'm sure the audience here would be more keen to see the data and hear about it and learn from you all. So thank you so much for a wonderful evening and a good discussion. Thank you. Thank you, Dr. Parveen. Thank you, Dr. Shalabh, and thank you, Dr. Ankur. And I would like to thank all the audiences who are listening to it. So thank you so much for your valuable time. Have a great evening ahead.
Thank you, Pfizer, and thank you, my panelists. Thank you, audiences, for patient listening. Thank you.
Thank you so much.
Thank you.
Thank you, sir.